I hand over the session to Professor and students. Over to Dr. Vidya, please.
So, good evening to all. So, my question is 45-year-old female with known case of pulmonary TB developed spontaneous pneumothorax after a bout of coughing. Clinical presentation and management, sir. So, first of all, pneumothorax is presence of air within the pleural space between the visceral and the parietal pleura, which indicates the loss of pleural membrane integrity, allowing the air from the environment or from the respiratory tract to accumulate within the pleural space. Etiology can be spontaneous or acquired. Under spontaneous, it could be primary or secondary, where primary without any underlying cause or pathology, wherein secondary, which is secondary to any underlying lung parenchymal pathology, for example, COPD, pulmonary tuberculosis, cystic fibrosis, neoplasia, etc. As this case gives the history of pulmonary TB, the cause could be pulmonary tuberculosis. Pathophysiology, normally there is a negative pleural pressure which helps in the lung expansion because of loss of integrity of pleural space. Negative pressure is abolished, which hinder the expansion of lung, leading to lung collapse, which leading to respiratory and the cardiovascular compliances. Clinical features is because of impaired ventilation and oxygenation, and the degree is based on the severity. So because of lung collapse, there is decrease in the tidal volume, hypoventilation leading to hypoxemia, hypercarbia, and respiratory acidosis, where the peripheral chemoreceptors and the mechanoreceptors increases the respiratory drive, leading to increase in the respiratory rate and the inspiratory force. Decrease in the static and the dynamic compliances, leading to increase in the work of breathing. And atelectasis and lung collapse will add on to cause hypoxemia. Cardiovascular system, because of usually the negative intrathoracic pressure during inspiration helps in increase in venous return. Here the venous return is impaired, leading to cardiovascular instability. Clinical presentation, we have to history wise we have to rule out any underlying lung pathology like pulmonary TB or COPD, whether the patient is on ATT or not on any treatment, whether there is history of recurrent spontaneous pneumothorax. If there is no history of apparent TB, we have to ask for any contact history of tuberculosis in the family. The clinical symptoms could be cough, breathing difficulty, chest pain, tachypnea, dyspnea. Based on the severity, the patient may present with respiratory and cardiovascular compromise with cyanosis and other symptoms like pleuritic chest pain. Spontaneous pneumothorax, usually patient will develop suddenly, like usually after a history of cough. On examination, general examination, we have to look for the pattern of breathing, engorgement of neck veins, whether the patient has any pallor, cyanosis, clubbing, lymphadenopathy leading to TB or any other underlying pathology, peripheral edema in case of cor pulmonale. We have to measure the vitals, baseline BP, respiratory rate, saturation. We have to look for temperature. Is there any active lung infection? We have to measure the baseline saturation. Respiratory system, on inspection, we have to look for tracheal deviation, use of any accessory muscles, bilateral equal chest movements. There is any scars from previous ICD insertion. On palpation, confirm the findings of inspection. On percussion note, increase resonance on the side of pneumothorax. On auscultation, decreased breath sound, reduced air entry on the side of pneumothorax. We have to look for any added sounds like wheeze, rhonchi, and creps. In cardiovascular system, you have to look for any raised IJV, peripheral edema. We have to auscultate and look for heart sounds. Management, in case of large volume pneumothorax presenting with respiratory or cardiovascular compromise, stabilization is the primary consideration with the help of history, clinical findings, or point of care ultrasound findings, which is loss of lung sliding, loss of seashore sign. We have to perform an immediate thoracocentesis along with O2 supplementation. A radiography can be delayed until the patient is stable. If the patient is asymptomatic or minimally symptomatic, they can be taken for further investigations, and they can be managed conservatively with monitoring and observation. Other investigations like CBC, blood gas analysis, ECG, echo, and CT chest, which is gold standard to rule out the underlying lung pathology and bullae, which also helps in detecting a very small volume of air. Once pneumothorax is diagnosed and the patient is stabilized, it is important to determine the underlying cause, and we have to treat the underlying cause to prevent the sequelae and recurrent pneumothoraxis. When it comes to ICD, ICD is usually placed in the 4th or 5th intercostal space at mid-axillary line in the area of triangle of safety. Before inserting the ICD, we have to inform the patient, we have to get the consent, we have to pre-medicate the patient, and a sterile aseptic precaution. After giving local infiltration, a blunt dissection is applied. Then we have to secure the drain tube, suture it, and connect it to the underwater seal. ICD management, we have to avoid clamping. We have to examine the ICD once daily, and the ICD collecting chamber should be 100 centimeter below the draining site. Chest X-ray should be taken post ICD insertion. That's all.
Okay. So if you observe today's all the 5 questions, do you finding anything common in that?
All are emergencies.
All very good. All are emergency situations or critical incidences that can happen, either related to requiring some anesthesia or intensive care therapy treatment. Okay, so that is the pattern of clinical scenarios that has been given to you today's discussion. And in this particular description, you have done a good job of describing right from the etiology, what happens in the clinical presentation, and how to manage. That's the correct way to do that. But there are 2 things that are missing. What is tension pneumothorax? That word has not been used at all. Okay. So a spontaneous pneumothorax in a patient with a pulmonary tuberculosis, what is the mechanism? How can it happen? You said it can happen after a bout of cough.
Yes,
so how does the bout of cough result in a air leaking into the pleural space and causing a pneumothorax?
So if there is an underlying pathology, there will be repeated inflammation and injury to the
There must be
alveolar
some
membrane.
weak point in some of the alveoli. Maybe a small bulla or a stretched out emphysematous alveoli, which can give tear or give way when there is a persistent increase in the airway pressures, okay, by coughing. So that causes the release and also tears the visceral pleura for the air too. So in this case, in most of the spontaneous pneumothorax, it is a leak from the parenchymal tissue and not from extraneous tissue. Whereas in open pneumothorax, what will happen?
Air from the environment goes into the
There is a penetrating injury to the chest wall, so air can get dragged or absorbed into the pleural space, and it cannot go back because the opening acts as a one-way valve, so it allows only aspiration or indrawing of the air and not allowing it to go back, and that will cause accumulation over a period of time. Whereas in spontaneous pneumothorax, majority of the time when it is very high volume going into the pleural space, it invariably results in a condition of acute distress resulting in tension pneumothorax. Okay, and if it is how will you clinically find out whether it is a tension pneumothorax or it is a non-tension pneumothorax, small amount of pneumothorax? What is the minimal amount which will not produce any symptoms, and what is the amount required to produce a state of tension pneumothorax?
So more than 500 500
Is by
ml.
volume or is it by percentage? 15% of accumulation of the space in the pleural area, it will not cause much of clinical symptoms. More than that only will be causing symptoms, and that too, if it is happening as a tension pneumothorax, it will suddenly collapse the lung on the side of pneumothorax, and it will push the mediastinum to the opposite side because of the pressure that is accumulating in the pleural space. It will cause a mediastinal shift also. So this will result in a sudden hemodynamic imbalance also. So that is the thing that we are worried about. So in such situation, there may not be enough time to release the air by intercostal drainage. So in such situation, what is the emergency treatment that you can do? That has to be described a little bit more in your, that can be asked at the practical exam also. So first emergency treatment to save the patient's life is you have to do a wide bore needle thoracostomy. How do you do that? Supposing you are seeing a spontaneous tension pneumothorax in the ICU in a patient who is admitted, and you see all the clinical features of hyperresonance on the side of pneumothorax, mediastinal shift, patient is tachycardic, hypotensive, tachypneic, desaturating, and you make a clinical diagnosis that it is a case of right-sided tension pneumothorax. So in order to save the life of the patient, what should you do? How will you organize a needle thoracostomy with the available things in the ICU? You don't have a proper ICD set and equipments for all that. So how to do a needle thoracostomy to save the life of the patient?
So we can use a wide bore hypodermic needle.
Hypodermic, or is it better to use something else which is available? What is the risk of using a hypodermic needle?
Can cause lung injury.
That can cause by itself a lung injury, and because what is going to be the site of insertion?
The second intercostal space in the mid-clavicular line.
Mid-clavicular line, very good. So either whichever side there is a pneumothorax, the site for needle thoracostomy is intercostal space, second intercostal space in the mid-clavicular line is supposed to be the safest area. So you may have a 14 or a 16 gauge Venflon in your ICU, which may be available. Okay. Yes, so you can puncture the pleura with the Venflon and remove the needle, so that cannula may not damage the underlying lung tissue, but at the same time it will help to remove the air. And how will you drain the air? You can puncture, but you cannot leave it open for the air to drain. It may, in fact, absorb more air from the, it may become an open pneumothorax and absorb air. So how to connect that to the drain? And there is no proper ICD drain bottles and other things.
So we can use rice tube or IV drain.
You can use an IV set. Regular IV set can be connected, and then you can make a collapsible IV fluid bags are there. You just discard half of the volume and then connect the IV set to the IV bag, collapsible sachets, and that will act as a underwater seal, and you can drain that for emergency until you make a regular thoracostomy. Okay, ICD in between. What is you said about the safe triangle where you have to make a insertion of the ICD tube? So normal question they may ask you is, what is the boundaries of this safe triangle?
So the apex is below the axilla, sir. Lateral border is the medial border, lateral border of latiss dorsi, and medially it is the upper border of the ipsilateral nipples.
Border of the nipple. So there is no muscle on the medial side?
posterior border of pectoralis major.
Pectoralis muscle. Pectoralis, latissimus dorsi, and the
Latissimus
axis.
dorsal.
Okay, so that is how the whole thing is planned. So this sort of cases can be discussed in the practical exam, and that is the reason for this. So I'll just share the PPT. All the presentations today are not complete spoon feeding PPTs to give you the descriptions as you have prepared. It is all some important points which you have to remember from the Viva angle, so that any questions asked on that you can easily answer. And this is not like a theory presentation where you have to start saying from the etiology, clinical diagnosis, signs and symptoms, investigations. It is not in that order. It is mainly from the angle of facing the exam with questions from the examiners. Okay. This only. So this is the case scenario that you have now heard. 45 years old female, known case of pulmonary tuberculosis, develops spontaneous pneumothorax or a bout of cough. What will be the clinical presentation? How to manage? So, first question that may be asked is, how is pneumothorax classified and what type is this particular one? So it can be classified as either primary or secondary. So as he rightly said, if it is a primary, there is no underlying pathology. So it is a normal lung where out of the blue suddenly patient develops a pneumothorax. Whereas if it is a secondary, there is some underlying pathology. As he rightly said, COPD, tuberculosis, or other pathological conditions. And this condition is secondary pneumothorax since the patient has an underlying tuberculous lung pathology. So clinical symptoms and how is it diagnosed? Patients may present with symptoms such as tachycardia and dyspnea. The diagnosis of spontaneous pneumothorax is based on clinical suspicion and can be confirmed by X-ray chest, ultrasound, or a CT scan. And in the X-ray chest, what will be the finding? Many times in the OSCE, you get a X-ray showing a pneumothorax. So what are all the findings you will see in a X-ray chest?
Sir, there will be, if there is a massive pneumothorax, tracheal deviation, and there is a distance between the pleura and the lung border, lung collapse on the side of the pneumothorax.
So how is it made out, that lung collapse?
The lung tissue will be seen with the surrounding hyperechoic, anechoic.
Absence of bronchovascular markings on the side of pneumothorax. Okay, that is the description that you have to say. Total absence of bronchovascular markings and pushing the lung towards the mediastinum and or the cardiac shadow as a small bunch. Okay, so that is the classical feature of a pneumothorax X-ray chest. And this ABG indicated in this case, yes, why?
Sir, the patient will be hypoventilating and the patient will have hypoxemia, hypercarbia, and acidosis leading to respiratory failures.
Right from the beginning or late in the, if it is not, if it takes time to treat it. When will it happen? The description of ABG that you are giving, will it happen at the very beginning of pneumothorax or will it happen late in the pneumothorax?
As a sequel of pneumothorax after some period of time.
Because initially patient will try to, it's not necessary for diagnosis of spontaneous pneumothorax. That is the main thing. It may be useful in assessing acute respiratory alkalosis because the patient will be tachypneic initially to maintain his oxygenation and removal of carbon dioxide. And this increases the alveolar arterial oxygen gradient in tension pneumothorax is present. And what is the management? You already said, but 100% oxygen via a non-rebreather mask, continuous cardiopulmonary monitoring, and remove the gas from the pleural space by proper drainage. These are the three basic things. And tension pneumothorax can be treated by emergent needle decompression as a bridge to tube thoracostomy placement. What is the difference in management between primary and secondary pneumothorax?
So in secondary pneumothorax, we have to, after stabilizing the patient, we have to treat the underlying lung pathology.
Okay. The correct answer, patients with first episode of primary spontaneous pneumothorax that is small and asymptomatic are conservatively treated. Okay. So the primary spontaneous pneumothorax, mostly it will be very, very small and mild. That is why I asked you about what percentage is required. So it may be only 15% of the total pleural capacity. If that is so, that is that won't produce much of a clinical picture. And primary spontaneous pneumothorax that is large or symptomatic, then only you require to drain it. Otherwise, it can be conservatively managed. And secondary spontaneous pneumothorax, regardless of the stability of the patient and the size of the pneumothorax, should be admitted in hospital and observed, because that can gradually increase in size and become a spontaneous pneumothorax. So that is the small difference between the primary and secondary pneumothorax management. Otherwise, all the questions about safe triangle, how to insert it, and what are the types of ICD drains that you know of?
So with single, double chamber, triple chamber.
Single bottle, double and three bottles. What is the difference? When will you use a 3-bottle ICD drain? Whenever you require a rapid expansion of the lung, especially after cardiothoracic surgery, whenever you want to expand the lung post thoracotomy, when you can apply negative pressure aspiration, okay, and then try to expand the lung and remove the drain as early as possible. That is the only reason for doing the 3-chamber drainage. Okay, and it will give you an idea about the fluid that is drained from the pleural space. In the 3-chamber, you can exactly measure the fluid that is removed compared to the other two systems of single and double bottle drainage. Okay, these are the two advantages that you have to remember. Okay. That is the description of spontaneous pneumothorax. Now, shall we go to the next